Hi, everybody, and welcome to the Kidney Coach YouTube channel. I am naturopath Fiona Chin, co-founder of the Kidney Coach and Kaigenesis, a range of supplements that we have specially formulated and designed for people with impaired renal function. And I'm joined again today by one of my favorite people in the entire universe, the lovely, the wonderful, amazing Lindsey Zirker. Lindsey is a brainiac, and as well as being a brainiac, she's also a renal dietitian, and she works alongside Jessie Anna Seville at the Kidney Nutritional Institute over in the USA. And why I love talking to Lindsey so much, and we always have these amazing conversations before we hit record, is her brain works very similarly to mine. So she's been wading through the research, as have I, trying to find the best way to, or the best research around renal diets and protein, and we were just talking about that. So Lindsey, as always, it's a pleasure to have you on the podcast. Welcome back.
Thanks so much, Fiona. I always love our conversations during the podcast and before and after as well.
Yes, you and me both. I always learn a lot from you. So we've been making our way through the wonderful world of minerals and their relationship to kidney disease. I think last time we spoke about selenium, and today we're going to talk about our friend iron, because it is such a big one when it comes to kidney function and renal disease. So I'm just going to hand it straight across to you. My friend, tell me iron. Let's dive down the rabbit hole. What do people with chronic kidney disease need to know about this amazing mineral?
Well, I think the thing to start off with, which is what I was mentioning to you right before we started, is that iron and anemia, they're very much linked, but there are separations in kidney disease.
Mm.
And I think that's really, really important for our people with kidney disease to understand, because um, anemia isn't always caused by an iron deficiency, although it often is.
Mm.
And also that iron deficiency isn't always caused by just not eating enough iron in kidney disease, also. And so I think it's important to understand that. And I was thinking about iron earlier today, and I was like, I feel like iron is like someone that has really, really extra controlling parents. Like, right? Because the hormones, we've talked about this before with minerals, a lot of times hormones are running the show. They are
Mm.
determining if this nutrient is going to get absorbed, how much is released into the bloodstream, how much is going to be stored. And with iron, I feel like that control is even tighter. And it's just like parents saying, no, you are grounded. You will stay in your room. The iron's going to stay in storage. No, you cannot have friends come over. No more iron will be absorbed. And all these kind of things. And I think that that's an interesting way to think about iron, because a lot of times it gets oversimplified and we miss the root issue going on with people's iron. So
That's such a great point. Controlling parents. That one, that's great. So, so let's talk about those hormones that really have. Let's talk about the parents, the hormones that regulate iron. Let's go into that since you've started there. So, tell me more about that and that relationship to iron, and why these hormones may or may not ground or send iron out to play with their friends.
yes. So one that we hear a lot about in kidney disease, that is sort of related with iron, is erythropoietin, which is made by the kidneys. And that is the messenger that goes to the bone marrow and says, hey, we need more red blood cells. And then the bone marrow will incorporate iron into the hemoglobin and red blood cells. And then we have, obviously it's a little more complicated than that, and there's more nutrients involved there. But so that is one that um, is we're really familiar with in talking about anemia. And people who have kidney disease, as their function declines, their kidney's not very good at sending that messenger out. And so
Mhm.
that can leave patients with enough iron, but there's no bone marrow incorporating, telling it, hey, you need to get and turning it into the red blood cell.
Right.
Um, and then also when, people's hemoglobin levels get low enough, they can get the infusions or injections of the synthetic erythropoietin. Um, and then we have a functional iron deficiency, because all of a sudden there's this huge burst of, ah, hurry, make more red blood cells. And then the body doesn't have enough iron to keep up with that. So that can be a challenge. Another hormone, though, that doesn't really get talked about a lot, this is, I feel like, the more parental controlling hormone, is hepcidin.
Mm,
So hepcidin is really going to regulate um, whether the body's going to absorb iron, if it's going to stay in its storage form or not. Um, and so hepcidin levels, they should respond if someone's iron levels are low. Then hepcidin levels should also drop and say, all right, invite all your friends over. It's time for a party. But in chronic disease like kidney disease or any kind of inflammatory state, hepcidin levels will be higher. And
mhm.
that is going to put a stop to all iron absorption, and it's going to sequester iron in its storage form so that iron can't be used to feed pathogens or get oxidized and create more oxidative stress and stuff like that. And so that one's tricky because there isn't really any reliable test to test hepcidin that I know of. I think they're
No.
still trying to isolate it. And like any hormone, hormone testing is tricky because there's different forms, or there's going to be different ups and downs. There's lots of circadian rhythm kind of stuff. I don't know if that's with hepcidin, but that's how it is with most hormones. Like, even think about parathyroid hormone. When you look at your labs, it's IPTH. You're looking specifically for intact PTH, which tells you that there's non-intact PTH also floating around there. So hormones are kind of shifty to try and test for, and so it's difficult to know, like, oh, what's going on with my iron? Is it because my hepcidin's high? So we kind of have to be really detective-y and just kind of draw some conclusions based on other types of labs to figure out what's going on with iron in our bodies.
So when in Australia anyway, when we're testing iron and we do a full iron panel, and I'm not just talking about the basic test that sometimes does my nana in that gets run, which is just iron and nothing else, but we will get iron, ferritin, transferritin, saturation, and then we'll look at total binding iron capacity, and then I will look at hemoglobin. Is that a sort of standard panel that you'd be getting?
That's what I would recommend. It I find that anemia and iron status is something that most of my patients really have to advocate for themselves for, especially if their hemoglobin is normal. And it is very normal to have normal hemoglobin and be like completely, almost completely out of iron. Like, it's one of the last indicators to drop. And so, yeah, a lot of my patients, they don't really get that. But if you have a great doctor who's willing to look into your anemia, those are definitely the labs that I would recommend. Sometimes I would also recommend getting a B12 and a folate if the mean corpuscular value that shows up in the regular blood panel, the CM or the CBC, if that
Yeah.
level is high,
Yeah.
then that would tell you maybe you need some B12 or folate. If that level's low, that could indicate iron needs. So I'd look at
Yeah,
that too.
exactly. So when you're looking at an iron panel, a full panel that we've just spoken about, what are some of the things, if people's hemoglobins come back as normal, let's even say their mean corpuscular hemoglobin concentration and the MCVs and all of those kind of things also maybe swinging on the low end of normal, what other markers inside an iron panel would you go, okay, I need to think about iron?
So I do take a look at the ferritin. This can be an indication of maybe if something is going on with the hepcidin, because ferritin storage levels tend to be higher in people who are inflamed. And so if we're seeing kind of some weird levels, but we see a high level of ferritin, then that would tell me maybe the real true issue here is not that someone is not getting enough iron. The iron is there. We need to work on the person's different inflammatory pathways so that the parental controls can be lifted and the body will release some of that iron.
Mm.
Um, and vitamin D and vitamin C are also key factors in helping with reducing hepcidin levels and releasing ferritin out of storage. So it kind of goes back to what we always talk about is making sure the person is well nourished overall.
Mhm.
Because if one nutrient is off, then probably other ones are as well. So, um, okay, so I look at ferritin to kind of see if inflammation is an issue that I need to look at for the iron. Um, you were asking specifically about labs.
Yeah, and just other ones. So I agree with you. Ferritin's the first one I go to see if there's inflammation in there. Are you looking? I don't actually pay much attention to the total iron generally. I'm generally looking at ferritin and hemoglobin, but are you looking at total iron binding capacity,
Yeah.
storage, all of those kind of things? Is there a picture that you have in mind where you'll go, yes, I will? Because your point is right, and this is what I look at, is if there's elevated ferritin, I will never supplement and put in more iron, because you're right, the iron's there and it's inflammatory, and I don't want to give more and cause more oxidative stress and damage inside
Yeah.
the body. So walk me through what things you would be like, okay, I might actually need to think about supplementing with iron.
Yeah, so if the ferritin is low, then that is definitely something. And like you mentioned, the transferrin saturation, if that level is lower, then I would definitely be looking at that. And the total iron binding capacity, if that's high, then that would also be an indication that we need to take a look and see, let's add some more iron in. I also don't pay attention to serum iron. I just feel like it doesn't really say anything.
No, I agree. It's one number I literally don't look at it. I'm looking at everything else bar that, really.
Yeah, I really don't look at it. Um, Let me see if there is anything else. No, those are the main ones. Sometimes you can look too at the red blood cells themselves if they're microcytic. So if they're small, that's where that lower mean corpuscular volume comes into play. And if they're hypochromic, so if the red blood cells are anemic
Yeah.
because they're all pale, um,
Yes.
then that would be another indication.
Yeah, no, they're exactly how I would look at it as well. And when you are coming to supplement with iron, do you go, okay, I'm going to try and do it through dietary factors first? Or are you looking at the diet and going, actually, that should be okay, so that's a gut absorption issue? Walk me through your process about supplementing with iron, what type of iron you supplement, when you would go diet versus actually supplementing with iron, and when you're also thinking the gut might actually be the issue here versus the intake, and when you're optimizing gut function.
Yeah, I think it is really important to be asking, why is this person not getting enough iron? So is it because they're not getting enough from their diet, or are they not absorbing enough? So that's where, I take a look and, have them keep some food logs and we see like what's going on there. And I think, the we have the recommendations for how much people with iron need, and of course it gets kind of complicated if you're male or female, menstruating or not, if you're fully plant-based or not. Like there's going to be different iron needs. But you can, to see if it's like, oh, you're getting 5 milligrams of iron a day. Like that's just not going to be enough for anybody. So I take a look at that and see now if somebody, I look at their food logs and it says they're getting, say 15 milligrams of iron from their diet, but I'm seeing really low levels, then I'm definitely going to be asking myself, is this an absorption issue or is this an increased needs issue? And
Mm.
so you're just going to have to be asking yourselves a lot of questions. I feel like one of the great gifts of being a good practitioner is being curious. Why is this way? Okay. And you just kind of keep looking upstream. Well, why is this doing this? Is it because of that? Um, And so, like just the other day, I had a transplant patient tell me that she woke up one morning and where her incision was, she had this huge bruise.
Oh,
And but right before that, she'd been telling me, yeah, for some reason my hemoglobin levels have been dropping and all of a sudden they popped right up. And then she told me she had that bruise. And I was like, well, what happened when you called your doctor about the bruise? It's like they took me off my Eliquis, my blood thinner. Suddenly her hemoglobin levels are better and the bruise is gone. And so that's a situation where, like, oh, this person's hemoglobin levels are dropping. They should have been asking why. And if they had done any kind of ultrasound or imaging, they would have been like, you're bleeding internally. Like, let's get you off this blood thinner. Luckily, it worked out for her anyway. But I think asking yourselves why that's happening is really important. And, if it's gut issue related, usually there's probably going to be some other symptoms, like lots of gas or bloating or heartburn or things like that. Or maybe they're on medications that lower stomach acid. That's going to lower your ability to digest iron. Maybe you're eating too much what we call non-heme iron, so the absorbability of the iron is very low.
mm,
Maybe you have a vitamin C deficiency, and so those two combined, that's an absorption issue that's not necessarily a gut problem per se.
yeah.
So I think it's really important that the practitioner can think through those things. And I think as far as like, am I going to go food first? Am I going to do supplements or whatever? I think that the biggest factor in telling me with that is going to be how severe are their symptoms.
Mhm.
Because I've had a hemoglobin of 9.6 before. It was
Oh,
very
wow.
unpleasant.
That is
I did
low.
not feel good.
No.
I was always out of breath. I was so tired. I was so cold. Like, I know what it is like to be really, really anemic. And
Mm,
I think that when you have experienced it for yourself, you see, like, you understand the major quality of life issue that it is. Like, and I think that too many practitioners, they don't understand that. And so they're like, oh, well, it's not that low. You're fine. And it's like, you don't understand what that is like. I do,
mm,
so I am very like, let's see what we can do to reasonably raise these levels up as quickly as possible so that you can feel like a human person again. And
yeah.
I think the other thing too is that if you don't have enough iron in your body, then it's going to be very difficult for oxygen to get anywhere in your body. That is
Mm,
just going to have a cascading negative effect on everything.
mhm,
And so I tend to not be too conservative with my recommendations for anemia. Like I want it to be reasonable, but I feel like a lot of times, like I'm not going to say, oh, let's just add a couple iron foods and see how that does. If they're already showing, like if it's showing up in their labs that they're deficient, I'm not going to just say add a couple foods here. I'm going to say, let's add this supplement so that you can get a bunch extra so we can get you up to a normal status, then retest. And when things look normal, let's make sure that during that time we've also been building up your diet so that hopefully you don't need to have that supplement. But I just don't think that it's very fair for people to wait in that sad quality of life space and we can do something about it.
yeah, no, really good point. And interestingly, a lot of over the counter or doctor prescribed iron supplements are going to cause massive
Mm.
amounts of constipation because they're using Ferrograd, which is the brand in Australia. So there are obviously much better forms of iron that don't do that, that are much gentler on the gut. Walk me through the type of iron that you'd be prescribing, or if someone is thinking, I maybe need to take some iron. Because I'm anti the ferrograd because of its side effects on the gut. So what sort of forms are you thinking of?
Yeah, I agree. Here, most people will get prescribed ferrous sulfate
Yeah.
and yeah, bad gut situations. And it's like, I already feel crappy. And now, in order to feel less crappy, I have to take this supplement that is going to make me not go to the bathroom.
Yeah.
Okay. And it's gonna like No, it doesn't make sense. So, depending on where they're at, I like to use ferrous gluconate, ferrous fumarate, um, different types of iron citrate salts.
Hmm.
Um, and sometimes make sure, depending on what their vitamin C intake is like, make sure that there's vitamin C included in there. Um, also, uh, there's a it's called Lucky Ironfish, but I think there's a couple
Yes.
of other products here. It's kind of the same idea of a cast iron pan where if you cook acidic things in that cast iron pan, you're going to have iron leach into the food. And in this case, it is a little iron fish, and you can add some lemon juice or some other kind of acidic thing into water and boil the fish in there, and then you can get iron infused water,
Hmm.
which depending on how much iron someone is needing, I feel like is a really great option because it's not a pill and it's in their water, which they're already drinking. And it's going to be in smaller doses throughout the day. So it's way less likely to have any kind of GI effects. And it's not really that much extra effort. Some people it might be, but yeah.
I really like the iron fish as well. That is one of my favorite things too. If they're, if they're not falling on the floor with a hemoglobin of like 6, as you mentioned, then yeah, that's definitely something that I really like using as well.
Hmm.
Um, what's your takes? I know people ask on iron infusions because it's such I see a lot of side effects from iron infusions, especially where they haven't properly looked at the full iron panel. They've gone ahead and gone, oh, your iron is, this is what I see all the time, your iron's like 2, which is low. But their ferritin's been super high or something else has been in there. And of course, all they've gone and done is push a inflammatory pathway. So apart from being the obvious where full panels need to be done and it needs to be done on that, is there a time and a place for iron infusions?
I think that there can be. Um, I think that I also don't really like how the protocols are set up now, where it's just like this big giant dose of.
Mm.
I think that, well, yeah, no wonder people have weird side effects from that. And specifically for people with kidney disease, I think for most people, at least in the US, if your hemoglobin is like above 10, then you're not going to be getting a whole lot of care like with your you're not going to get it. It's like this very dialysis mindset, and that's the dialysis protocol. If your hemoglobin is below 10, then yeah, they'll do the EPO and iron and all that stuff. But until you get to that sad state, nothing is going to happen. And so um yeah, so I think for people who have a hemoglobin above 10, like they won't even have to worry about iron infusions here because your insurance is not going to pay for it. Like it's just
Mm.
not going to happen. But I do think that you know, you're probably going to have at least one bad experience getting the iron infusion, and then you can say, "Hey, this horrible thing happened last time I had an iron infusion. Is there any way that we can split this up?" Or,
Mm.
talk with the doctor, get a hematologist on board who can give some other opinions in a way that they can adjust the therapy so you're getting smaller, more reasonable amounts, but also have insurance pay for it.
Yeah, yeah, no,
That's the
exactly.
struggle.
It
Yeah.
is a struggle. No, I totally agree with all of those facts. Okay, what else do we need to talk about? What about food? So if we're going, okay, look, it's a little bit on the low side. We've got a little bit of gut work to do. I think I can do it mainly through diet. What are your favorite foods when it comes to increasing iron levels through the diet?
So the most bioavailable is going to be through animal proteins.
Mm.
That is going to have like more iron per calorie, however you want to think about it.
Yeah.
But as we know, sometimes, we have to have limited amounts of animal proteins because they're so protein dense, and that may not work for everyone's diet. So other foods that are quite high in iron would be lentils, spirulina, and chia seeds. Um,
Mm.
so because these are all plant foods, it's considered what, like I said earlier, that non-heme iron. And so if you have a food source of vitamin C when you have those foods, it's going to increase your absorption of those. So a lot of times I'll say, like if you're having the spirulina, like put it in a smoothie, like with some pineapple, um, or with the chia seeds, sometimes it'll be like, if you um the chia seeds is harder, but if sometimes people like to add that to salads, I'm like, have some fresh red pepper on your salad with that. Um Lentils, I'm like, I don't know, what do I say? Like add fresh tomatoes on top because vitamin
Mhm.
C is killed with any heat processing, so it's got to be fresh.
Yeah.
Uh, we don't want to just tell people have a glass of orange juice because the nephrology world would collectively have a heart attack. But um yeah. So, but I mean, just like thinking about foods that are high in vitamin C, which I'm looking at my cheat sheet here, it's not always oranges, even though they have awesome marketing, but actually Brussels sprouts, red peppers, broccoli, and pineapple are
Mhm.
really awesome sources of vitamin C. Actually, almost any pepper is going to be a great source of vitamin C. So if you like
Yeah.
spicy food, then yeah, have lentil tacos with some, pepper salsa. So,
Perfect.
yeah.
I love it. Excellent. All right. What else do we need to say about it? I know I will just say in clinical practice, if I've got a patient, and this isn't related to kidney disease, but with chronically low iron that cannot be palmed off with heavy periods and things like that, 9 times out of 10, parasites or food allergies. So I find microbleeding in the gut is the biggest cause of long-term chronic low iron. Food allergies actually being number one and parasites being number two. And once you take the food allergen out, generally it will be dairy. Dairy loves to cause microbleeding in the gut, as does a gluten sensitivity, not necessarily celiac
Yeah.
disease.
Mm-hmm.
Take those out and do gut healing, you'll find the iron will go up by itself. Same thing with parasites, and generally too, there's an inflammatory process that's sitting behind that. So that'd be my other takeaways. If you're someone that's listening to this that doesn't have kidney disease but have chronically low iron that you can't say is due to endometriosis or really heavy menstrual cycle blood loss, that's general, and there's no other sort of major cause. That's my go-to. I would say 9 out of 10 times it'll be some sort of gut inflammatory state being driven by some sort of microbiome imbalance or parasite, or also food allergies. They are so underrated when it comes to causing iron loss. So I wanted to add that in. Is there anything else you see in clinical practice, maybe more pertaining to kidney disease when it comes to iron?
So I was looking at my notes, a couple of things. So we've talked about vitamin C. If you have really low vitamin C levels, that's going to impair your ability to absorb iron. But copper and vitamin A also play a really important role in iron metabolism. And
Mm-hmm.
so low levels of those can be an issue as well. Um, and then I was like, oh, we didn't talk about the symptoms of iron deficiency outside
Oh,
of
yes.
anemia. And I thought,
Yes.
oh, we should
Yes.
talk about that because a lot of people with kidney disease, they're like, my hair is falling out. And so they like eat biotin supplements like crazy. And then their hair's still falling out. And then their labs are weird because biotin interferes with so many labs.
Yes, so that
Um,
very good point, Lindsay. Yes. Thank you. What are the symptoms of iron deficiency? We obviously have hair loss. What else have we got there?
Yeah, so hair loss. And then some of them are really non-specific, but they are also common things that it's just like, let's rule this out. It's easy to
Mhm.
do. Like fatigue, weakness, depression, heart palpitations, impaired thyroid and immune function.
Mhm.
One thing that I feel like is easy to look at is like brittle or spoon-shaped nails.
Hmm.
That can be um, a symptom. Taste bud atrophy or like a really sore tongue and also sores at the corners of the mouth, which
Hmm.
you can have that with other B vitamin deficiencies. And I think collectively, what those things all add up to would also be a protein deficiency. If you're getting enough protein, most likely you're probably getting enough B vitamins and you're probably getting enough iron. So if you're having multiple things going on in your mouth, you're probably like just eat, work with your provider to be like, how can I eat more protein and fix this?
Yeah.
Um, a really common one for iron is pica, which is when you want to
Mhm.
eat things that are not food, and specifically cravings for ice, which I did
Yes.
have. I was like craving snow cones like so insanely. And then I was like, I just need to, eat some beef here. So, let's see, other ones, cold intolerance, restless
Mhm.
leg, easy bruising, difficulty concentrating, shortness of breath, headaches. So again, there's a lot of, other things that could contribute to these symptoms, but there's some of these that are pretty specific to iron as well. So,
Yeah. No, really good points. And yes, I'm so glad that you reminded me to cover those major symptoms that we need to look at.
I know,
Um,
I got too
and
excited.
when we're looking at deficiencies and things like that, where does iron fit as far as being common, uncommon, medium of the chain when it comes to kidney disease? Because I think it's one that people are the most common thinking about linked to kidney disease because of, as we spoke about, anemia and EPO. Um, do you see it as being overly thought of as being just simply an iron issue when it generally is something else? Or is it legitimately iron deficiency in kidney disease is a thing? And really, with anyone with chronic kidney disease, we need to be keeping an eye on iron levels.
I think that iron issues are common, but I think that either like they don't get paid attention to because their hemoglobin isn't, below 10,
Mhm.
or it is below 10 and it's that functional iron deficiency that comes from like those big EPO shots. And
Mm.
then I think we have a lot of proactive, people who are like following low protein plant-based diets, but not maybe, thinking about, oh, if I'm eating 100% plant-based, I can't just have that minimum iron amount. I actually need to have a higher amount to make up for the lack of absorbability in those foods. So I do think it is pretty common. Um, and I think that if you have one deficiency, you probably have others.
Yeah.
So, I mean, I think we've talked about this study a couple times, but uh, there's this study that they did, and they had dietitians put together um, kidney friendly menus based on different eating patterns, like if they were going to be vegan or omnivore or like 50% plant-based or whatever. And then so they were like lower potassium, lower phosphorus, lower sodium, and then they had them at different protein levels, like ranging from like zero point 0.5 to zero point 0.8. And they said, here's how the nutrients pan out. And these were like really well organized menus. And they were sad for like lots of the nutrients for just barely meeting those RDAs. And
Like crazy.
all of them were didn't meet for like vitamin B6 and choline, but a lot of them, especially the lower protein ones, they did not meet the iron. And
Mm.
so, but they didn't correct in the study for the vegan needing higher iron either. So it was even lower than they kind of estimated. And so I just think that most people, like, you really have to eat a significant amount of food to meet micronutrient needs when you have chronic disease.
Mhm.
And a lot of times, like, that can really feel like a full-time job. And so it's really important to work with someone who can understand what your nutrient needs are based on the medications that you're taking, based on conditions you have, based on what your diet is like, what your symptoms are, and can help you craft a diet and a supplement regimen that is truly meeting those needs, isn't over supplementing you or under supplementing. I think it's really important, and also it'll be way less stressful than trying to figure it out on your own.
Oh, absolutely. And you'll be way less sad about tanking your nutrients and having to get them back up again and thinking normally again. So you can bypass that whole experimental crushing yourself pathway that I don't recommend.
Yes, yes.
As Lindsay would say, she did that one herself.
Yeah, I've been there with a lot of weird health issues. So not with kidney disease, but like anemia, not getting enough nutrients, gut issues. I have, and even like knowing what I know, I have still like not, it's hard to think of yourself as a patient. You really need other people on your team who can be from the outside looking at you and being like, did you remember this aspect of your health? Oh, sorry, I forgot that. So
No.
chronic disease is a lot to manage. So put a good team together to help you feel your best.
Exactly. I couldn't agree more. And if you want to have Lindsay on your chronic health disease team, I'll put her details in below, but you'll find her at the Kidney Nutritional Institute. Lindsay and the team are based in the US. So that means with insurance, they can telehealth you anywhere. And if you're anywhere in the world, because of also telehealth, you can also chat to Lindsay anywhere in the world. I highly recommend it if you want a very switched on not just renal dietitian, but dietitian that actually really understands minerals and hormones. Lindsay doesn't realize we're going to, once we get through the minerals, Lindsay, we're going to have to do a hormone one because she's just written a great big chapter for Spring of Nature for a kidney textbook, and she's now the hormone expert. She was mortified that she got asked to do hormones, but in true Lindsay style, she's now the hormone expert. So she's my go-to on all things hormones. So that's going to be our next length of podcast, Lindsay. I've got you now for at least the next 10 years. It's great. I will be, but that brain of yours is going to be mine by the end.
Well, we'll all learn a lot then.
We will. So if you want to know more about that, I'll put Lindsay's details in below. If you want to know more about what we do, head to www.kidneycoach.com. You'll also find us on Instagram and Facebook under the same names. Make sure you hit subscribe and like. That way you'll get notified anytime we put up more content. And if there are any particular minerals or questions that you have for Lindsay, put them in below and I will be sure to ask. We've got great feedback about our mineral series, Lindsay. Everybody's loving it. So do we know what mineral we're doing next? Have you got one in mind of what you want to do next time so our viewers know what to tune in for?
What have we not done? We haven't done phosphorus.
Oh, okay, let's do it. Yes. Actually, you know what? Someone actually said, is there a podcast on phosphorus? And I'm like, Jess and I have done a basic one, but let's do phosphorus because I literally got asked about that one on a YouTube question a couple of days ago. So done, phosphorus. So there you go.
Okay.
Tune in for our next one. It'll be on phosphorus. Lindsay, thank you as always for sharing your wisdom, and for everyone listening, thank you for being part of our community. We appreciate all of you. Bye.